So thank you, Alain. So the aim of my presentation is to focus on the proximal nerve block, I mean femoral nerve block, an obturator nerve block for hip arthroplasty and TKA. Well, femoral nerve block, an obturator nerve block, emerges from the lumbar plexus. The lumbar plexus is constituted by nerve roots L1, L2, L3, and L4. And femoral and obturator nerve blocks run inside the psoas muscle and have a vertical direction into the pelvis. And then femoral nerve block changes its direction to go between the psoas and the iliacus muscle to emerge from the pelvis on the anterior side of the bone between the iliacus and the pubic bone under the iliacus ligament. The obturator nerve emerges more distally through the obturator foramen. Now to know what we can expect about these nerve blocks, we must focus on the innervation. We can see, first of all, the femoral nerve block in pink color and orange color. The first part on the left of this slide is the cutaneous innervation. And we can see that femoral nerve block allows the innervation of the anterior side of the thigh, the anterior and medial side of the knee, and the medial side of the leg to the internal malleolus. It innervates to the hip flexor, I mean the quadriceps and sartorius muscle. And for bone, femoral nerve block allows a large innervation of the anterior side of the femur from the head to the knee. It allows to an innervation of the patella and the tibial head. If we focus on the femoral head and femoral neck, we can see that femoral nerve allows 1 out of 3 parts of the femoral the femur. It's the anterior side. For the obturator nerve, the skin area is very little in the medial side of the thigh. It innervates to the adductor muscles of the hip. And for the bone, the area innervated by the obturator nerve is the medial side of the femur from the head to the knee. And it innervates 1 out of 3 parts of the head and the neck of the femur. So now the femoral nerve. So the femoral nerve on the iliacus fold runs directly on the top of the iliacus muscle here. And it is just covered by 2 sheaths, the fascia lata and the fascia iliaca. And the fascia iliaca is the ultimate sheath surrounding the psoas muscle and the femoral nerve. So the good image when we perform the femoral nerve block is when the local anesthetic spreads surrounding the nerve, but still under the artery. If the local anesthetic goes on the top of the artery, it is the wrong injection. We can see that femoral nerve block is constituted by different nerves. So when we inject the local anesthetic separate all these nerves, and we will have an image with different nerves inside the local anesthetic spread. It is a normal image after a femoral nerve block. The obturator is more medially. It is exposed medially to the femoral vein. It is divided in 2 branches. The anterior branch here, between the pectineus muscle and the adductor brevis muscle, we can find this branch between the adductor longus muscle and the adductor brevis muscle. And we perhaps we will see on our model later if we can follow this anterior branch. The posterior branch is between the adductor brevis and adductor magnus branches. In 10 to 30%, we have accessory obturator completely separated from these branches, and it allows the innervation of the hip joint. It's important to know that in 10 to 30%, we have this innervation. So now, what about the indications? Femoral nerve block, it is well indicated for hip fractures. It allows a good analgesia level and allows a muscle contracture relief, which permits the good analgesia with morphine sparing. So it is a very good technique for hip fracture. Furthermore, this femoral nerve block must be done very quickly as possible, if possible in the emergency room, to allow the analgesia without morphine use. Other trauma of femur and knee trauma are good indication too for the femoral nerve. For knee surgery, femoral nerve could be used as an anesthetic technique with the addition of sciatic nerve, obturator nerve, and lateral cutaneous nerve of the thigh. Or it could be used as an analgesic technique alone or in association with the obturator and the sciatic nerve. The question is, what about hip replacement? At the moment, we cannot use femoral nerve block daily for hip replacement because femoral nerve induces quadriceps weakness, and that forbids the early walk of the patient. But we can use femoral nerve block in special indications like total hip prosthesis replacement when patient will be not able to walk the day of the surgery. And so in this case, we can use femoral nerve block even if femoral nerve block is not usually used for total hip replacement. The obturator nerve is less used, but it enhances with in addition of femoral nerve block, it enhances the analgesia level for knee and hip surgery. So it is logic when we focus on its innervation area. So it's a good analgesia technique added to femoral nerve block for knee surgery. What about hip surgery? In some cadaveric studies, injecting 15 milliliters below the pectineus induces 100% of diffusion to the obturator foramen. That leads to anesthesia, all the branches of the obturator nerve, including the hip branches. And this is very important because obturator nerve block doesn't does permit the early ambulation. But this point still debated, and in our team we are performing at the moment a study to specify this point.
Okay. Thank you, Olivier. You can go to the live model. During this time, I just have to say that you can ask questions. It's extremely important for me, you to ask a lot of questions. And for example, if you want to have some tips or some discussion about obturator nerve block or femoral nerve blocks, you can immediately ask your question, and I will ask a question to the speaker. So I'm going to the other place and with my iPad, just waiting for your question in first. So you will see a femoral nerve block first, and then obturator nerve blocks. Over to you, Olivier.
So we begin with the femoral nerve block. So the patient is on a dorsal position. So we focus on the flexor, on the inguinal fold. We can see, I need more gel. Yes, okay, we have a good image now. We can see if we go more deeper, we can see, yes, the hip. We can see the hip joint, okay. And more proximally, we have the femoral artery, and medially to the femoral artery, we can see the femoral vein, excuse me. So laterally to the femoral artery, we can see the femoral nerve. The femoral nerve is very flat on this image because it's just running on the iliacus muscle. Okay, the iliacus muscle here, and it is running just on the iliacus muscle, and it is surrounded by different sheaths, and the fascia iliaca sheath is there. So it is normal to have a nerve very flat on this area. This is for the femoral nerve.
Perfect.
So there are different approaches to the femoral nerve. Of course, we can do an in-plane approach with a lateral to medial approach. We can have an out-of-plane approach, especially when we want to perform a catheter. And in this case, we have to inject first to this coin, excuse me, in this coin of the nerve to avoid a direct puncture of the nerve, and we inject local anesthetic, and inside the spread of local anesthetic we will be able to move the needle inside the local anesthetic spread, so it will be safe for the patient.
Perfect. Can you see sometimes some artery in the nerve?
Yes, sometimes there is an accessory artery which leaves the femoral artery and which run on the top of the nerve or inside the nerve. Mm-hmm. So it is very important to search this accessory artery to avoid a direct puncture and avoid a local anesthetic injection inside the artery. But we do not have this artery in our model.
And performing a femoral block, is it the same for total hip replacement or total knee replacement? Is it the same technique, same approach, same thing? Or do you think you have a difference in doing the block for one or the other joint?
No, it is the same technique for hip and knee surgery. But for hip surgery, it was we used to perform femoral nerve block for hip surgery few years ago. But now with ERAS program, we do not use daily this practice for hip surgery. We use it for hip fracture. Yes. Okay. And for hip fracture, it is very important because it allows a very good analgesia level without use of morphine, with morphine sparing. And it is very important on elderly patients. And in my opinion, it is very important to perform this block very early, if possible in the emergency room, to have a very pain relief for this patient.
Okay. So, okay, now we can go to obturator nerve.
So the obturator nerve, we are in the same area, and we just have to move medially. So we have the femoral nerve laterally to medially. We have the femoral nerve, then the femoral artery, and the femoral vein. We can have a more deep exploration. Okay, and the femoral vein is always run on a muscle. It is the pectineus muscle. The pectineus muscle is like a bird. We can see It is like a bird, like the head of a bird, or a tanche. It is a fish in French. And we have two branches of the obturator nerve. The first branch, the anterior branch, is running between the pectineus muscle and the adductor brevis muscle. I need to, okay, excuse me. And the posterior branch is between the adductor brevis here and the adductor magnus muscle. It is here. So the injection is very easy. Personally, I use an in-plane technique, but you can use as you want, out-of-plane technique if you want. The point, you have to be care about the femoral vein, and sometimes we have to be very medially before performing this block to avoid the direct puncture of the femoral vein. We can see in our model, it is a very echoic patient, and we can see the anterior branches. Look, when I tilt my probe, we can see the movement of the anterior branch of the obturator nerve.
In this case, the same question than for the femoral nerve. Do you perform exactly the same technique when you want to use using the obturator nerve for hip surgery or knee surgery? For example, do you use anterior branch only or posterior branch only in one or the two cases?
Personally, I use all the time the two branches of the obturator nerve, because we know that there are some anatomic variation between patients, and if we choose to perform only an anesthesia of one branches of the obturator nerve, we can have a deficit in the anesthesia. There is a publication about the interest of obturator nerve for hip surgery. The problem is that we are distally than the hip joint. And how to perform an obturator nerve which is effective for hip surgery. And in some cadaveric studies, they found that injecting 15 milliliters below the pectineus muscle here induces a diffusion of local anesthetic to obturator foramen in 100%, and probably leads to anesthetize all the branches of the obturator nerve, including the branches to the hip. But this point still debated. So in our team, we organize at the moment a study to specify this point. But it is very interesting, because if it is a good technique, it allows the anesthesia of 1 out of 3 parts of the femoral neck, without ambulation problem, because obturator nerve allows only the innervation of the hip adductors, so the patient is able to walk immediately just after the surgery. But this point is still debated at the moment.
Okay, so I have the possibility to make in 2 injections or 1 on the main branch, a little bit proximally. But in your daily practice, you prefer the double injection than for knee surgery, particularly than only a main branch, the main branch. So thank you very much, Olivier. Now we will speak we'll speak with the second speaker.